So today we are going to study optic neuritis. Optic neuritis is a disease of optic nerve. So it is studied, the disease of the optic nerve are studied under various stuff. The first is congenital anomalies, optic neuritis, anti-ischemic optic neuropathy, papilloedema, optic atrophy, tumors. Of these, papilloedema and optic neuritis are of great importance. So first we will study optic neuritis. So what is optic neuritis? Optic neuritis includes inflammatory and demyelinating disorders of the optic nerve. Okay, so it is inflammatory and demyelinating disorders of the optic nerve. Next, what is the etiology of optic neuritis? Etiology includes idiopathic, then hereditary, third demyelinating disorders, fourth para-infectious causes, fifth infectious causes, and sixth toxic optic neuritis. So we have a mnemonic for this, that is HIDPP, that is HIDPIT. So H for hereditary optic neuritis, that is Leber's disease. Okay, I for idiopathic, that is a large proportion of the cases the underlying cause is unidentifiable, and last D is demyelinating disorders. These are the most common cause of optic neuritis. They include multiple sclerosis, neuromyelitis optica, that is Devick's disease, and diffuse periaxial encephalitis of Schilder. About 70% of the cases of established multiple sclerosis may develop optic neuritis. So the demyelinating disorders are: first, multiple sclerosis, out of which 70% lead to development of optic neuritis; then neuromyelitis optica, that is Devick's disease; and third, diffuse periaxial encephalitis of Schilder. Now PIT, P for para-infectious optic neuritis. It is associated with various viral infections such as measles, mumps, chickenpox, whooping cough, glandular fever. It may also occur following immunization. This is known as para-infectious optic neuritis. Okay, it is involved with various viral infections. Then fifth is I for infectious optic neuritis. It may be related with sinus, so acute ethmoiditis, or it is associated with cat scratch fever, syphilis during the primary or secondary stage, Lyme's disease, cryptococcal meningitis in patients with AIDS. Sixth is toxic optic neuritis, that is toxic amblyopias. So sixth etiology: HIDPIT, H for hereditary, which includes Leber's disease; I for idiopathic; D for demyelinating disorder, out of which multiple sclerosis is very important; P for para-infectious optic neuritis, which includes various viral infections; I for infectious optic neuritis, which may be related to sinusitis or syphilis and AIDS; T for toxic optic neuritis, that is toxic amblyopias. Now we will study the clinical profile of optic neuritis. Clinically, it is anatomically, optic neuritis is divided into three types. Okay, first is papillitis, second is neuroretinitis, third is retrobulbar neuritis. So what is papillitis? Papillitis involves optic disc. Okay, it only involves the optic disc. Neuroretinitis involves optic disc and the surrounding retina in the macular area. We have to remember that LMNO, L for lateral, M for macula. So macula is lateral, N for nasal, O for optic disc. So optic disc is nasal. So in papillitis, the nasal part is involved, that is the optic disc involved. In neuroretinitis, both the nasal, that is the optic disc, and the lateral, that is the macular area, is involved. In retrobulbar papillitis, in papillitis there is inflammatory and demyelinating disorder. It is usually unilateral, but sometimes it may be bilateral. Okay, moving on to retrobulbar neuritis. As the name suggests, it is characterized by involvement of optic nerve behind the eyeball. That is why it is known as retrobulbar. Clinical features of acute retrobulbar neuritis are essentially similar to that of acute papillitis. Okay, the difference is that the fundus changes and ocular changes. The differences are seen in the fundus changes and the ocular changes, but the clinical features are similar to papillitis. Moving on to the symptoms of optic neuritis. Optic neuritis may be asymptomatic or may be associated with the following symptoms. So the main symptoms that is with the patient complains are, first is the visual loss, second is dark adaptation hampering, third is visual obscuration in bright light, fourth is impairment of color vision, fifth is phosphenes, sixth is episodic transient obscuration of vision, seventh is depth perception, eighth is pain. So eight things: visual loss, dark adaptation may be lowered, visual obscuration, bright light, impairment of color vision, phosphenes, episodic transient obscuration of vision, depth perception and pain. So how is the visual loss? Visual loss is sudden, progressive and profound. It is the hallmark of acute optic neuritis. Sudden, profound, progressive visual loss. Dark adaptation is lowered. What is visual obscuration in bright light? Obscuration are transient losses. Transient means for a short period of time. That is graying out of vision lasting for a few seconds. It occurs in the context of raised intracranial pressure. Okay, especially activities known to elevate intracranial pressure are coughing, sneezing, bending down, straining at stool. It is relieved by their cessation. So this is visual obscuration. So here visual obscuration occurs in bright light. It is a typical symptom of acute optic neuritis. Okay, then impairment of color vision. It is always present in optic neuritis. Typically patient observes reduced vividness of saturated colors. Okay, next, movement phosphenes and sound induced phosphenes. So what is phosphenes basically? Phosphenes is a phenomenon characterized by the experiencing of light, seeing light without light actually entering the eye. The light actually does not enter the eye, but then we see light. The word phosphene comes from phos, that is light, and phene, that is to show. So phosphene means to show light. Phosphenes are induced by movement or sound and are often associated with optic neuritis. So this is an example of phosphene. You can see the color, glow color. This is the phosphene. Okay, so movement phosphenes and sound induced phosphenes may be perceived by patients with optic neuritis. Phosphenes refers to the glowing sensation produced by non-photic or inadequate stimuli. So it can be, see, this is the glowing sensation produced by non-photic or inadequate stimuli. Moving on to episodic transient obscuration of vision. So what does transient means? Transient means for a short period of time. So episodic, it will come in episodes. So short periods of episodes of obscuration of vision on exertion and exposure to heat, which recovers on resting or moving away from the heat. It is known as Uthoff's symptom. Very important. Okay, it occurs in patients with isolated optic neuritis. Next is depth perception. So what is depth perception? The person is not able to perceive the depth of the object, especially the moving object. It is known as Pulfritz phenomenon. So two phenomena. First is Uthoff symptoms and second is Pulfritz phenomenon. Pain. So patient complains of mild dull eye ache. Mild dull eye ache. It is more marked in patients with retrovalvular neuritis than with papillitis. Pain is usually aggravated by ocular movements. So why does it aggravate by ocular movements? Because when the eyeball moves upwards or downwards, there is an attachment of some fibers of optics of superior rectus to the dura mater. So when the eyeball moves upward or downward, there is pain. Got it? Moving on to signs of optic neuritis. First, visual acuity is usually markedly reduced. Color vision is severely impaired. Okay, visual acuity and color vision is damaged. Third, pupil. So changes seen in the pupil are, there is an ill sustained constriction to light. Okay, so Marcus gun pupil is seen. It indicates relative afferent pupillary defect. So it is an afferent pupillary defect. It is a diagnostic sign. It is detected by swinging flashlight test. So visual acuity, color vision and pupil showing ill sustained constriction to light, that is Marcus gun pupil, which shows relative afferent pupillary defect. Next, ophthalmoscopic features involve papillitis. In papillitis, it is seen that there is hyperemia of the disc, optic disc, which is situated nasally, is hyperemic, and the margins of the optic disc shows blurring. Then the disc becomes edematous and the physiological cup is obliterated. As the disc becomes edematous, the cup becomes obliterated. Retinal veins, the veins seen on the retina, are congested and tortuous. After congestion, there is hemorrhage, splinter, hemorrhage and fine exudates may be seen on the optic disc, which is situated nasally. On slit lamp examination, there are inflammatory cells in the vitreous. Okay. Next, inflammatory signs may also be present in the surrounding retina when papillitis is associated with macular star formation. This condition is known as neuroretinitis, as it involves both the optic disc and also the surrounding retina, mainly the macular part. Now moving on to retrobulbar neuritis. In retrobulbar neuritis, as the lesion is behind the eyeball, the fundus appears normal and condition is typically defined as a disease where neither the ophthalmologist nor the patient sees anything. Occasionally there may be temporal pallor of the disc. Okay, temporal pallor of the disc may be seen. Now what are the visual field changes seen in optic neuritis? The most common field defect in optic neuritis is a relatively central or centrocecal scotoma, that is a blind spot. Okay, other field defects seen are, they are very rare. Okay, they are paracentral nerve fiber bundle defect. Okay, then a nerve fiber bundle defect extending up to the periphery, and a nerve fiber bundle defect involving fixation point and periphery. So mainly there are nerve fiber bundle defects seen. Okay, the field defects are more marked to red color than the white color. Moving on to contrast sensitivity, it is impaired. So what do we mean by contrast sensitivity? Contrast sensitivity is a very important measure of visual function, especially in situations of low light or fog or glare, when the contrast between objects and their background is often reduced. Driving at night is an example of activity that requires good contrast sensitivity for safety. So patients of optic neuritis are not able to drive at night as their contrast sensitivity is impaired. Moving on to visually evoked response, that is VER. So what is visually evoked response? Visual evoked response visual evoked potential means the patient sits before a screen on which alternating checkered board pattern is seen and the response of the patient is seen. Okay, so this response, it shows a reduced amplitude in optic neuritis, and there is also a delay in the transmission time, that is delay in the response time. Okay, moving on to differential diagnosis of optic neuritis. So differential diagnosis involves papillitis. So papillitis should be differentiated from papilloedema and pseudopapilloedema. Next, acute retrobulbar neuritis should be differentiated from malingering hysterical blindness, cortical blindness and indirect optic neuropathy. So how does optic neuropathy evolve or recover, and what are the various complications of optic neuritis? In optic neuritis, typically visual acuity and color vision is progressively lost over the 2 to 5 days. Next, the rate of visual recovery is slower than the rate of visual loss. Okay, so visual recovery is slower than that of visual loss and usually takes 4 to 6 weeks for visual recovery. About 75 to 90% of the patient gets good visual recovery. However, recurrent attacks of acute retrobulbar neuritis followed by primary optic atrophy and recurrent attack of papillitis are followed by post-neuritic optic atrophy leading to complete blindness. See, recurrent attacks of acute retrobulbar neuritis are followed by primary optic atrophy. Okay, the optic nerve gets damaged. And recurrent attack of papillitis are followed by post-neuritic atrophy. Both of them lead to complete blindness. So how will you manage a case of optic neuritis? Effort should be made to find out and treat the underlying cause. Okay, so underlying cause should be established. There is no effective treatment for idiopathic and hereditary optic neuritis and that associated with demyelinating disorders. Okay, there is no specific or effective treatment for optic neuritis up till now. Corticosteroid therapy may shorten the visual loss but will not influence the ultimate level of visual recovery in patients. So there is very less change in the patient in terms of visual recovery, but then it will shorten the period of visual loss. Optic Neuritis treatment trial has made following recommendation for use of corticosteroids. First recommendation about oral prednisolone therapy. Oral prednisolone therapy is contraindicated in the treatment of acute optic neuritis. Why is it contraindicated? It is contraindicated as it does not improve visual outcome and it is associated with significant increase in the risk of new attacks of optic neuritis. Okay. Now a patient presenting with acute optic neuritis should have a brain MRI scan. It is very essential to do a brain MRI scan of a patient with optic neuritis. If the brain shows supportive lesions of multiple sclerosis, okay, regardless of the severity of the visual loss, each patient should receive immediate IV methylprednisolone. See, we are starting with immediate IV prednisolone. Methylprednisolone IV is given, that is 1 gram daily for 3 days. So after giving 1 gram daily for 3 days, that is 3 gram dose will be given already. We will follow it by oral prednisolone 1 milligram per kg per day for 11 days. So if a patient is weighing 70 kgs, we will give him 70 milligram per day oral prednisolone for 11 days. Okay. This therapy will delay conversion to clinical multiple sclerosis over the next 2 years. It can only delay. Okay. Third, what are the indications for IV methylprednisolone in acute optic neuritis patient with a normal MRI normal MRI of brain? So first indication is visual loss in both the eyes simultaneously. If the visual loss occurs simultaneously, give him IV methylprednisolone 1 gram per day for 3 days. Or if the visual loss takes place subsequently within hours or days of each other, that is in both the eyes. If one eye visual loss is there and subsequently within hours or days there is visual loss in the other eye, give him IV methylprednisolone 1 gram for 3 days. Then when the only good eye, okay, the only good eye is also affected, then you can give it. Or third, when the slow progressive visual loss continues to occur. So these are the 3 indications for IV methylprednisolone with a normal brain MRI.